Hi, welcome, good afternoon. This is Peter and his colleague Petra, and they are going to be interpreting for us today. So you'll see them rotating on and off the stage as we go through. Welcome to you all, online and also in person. It's an honour to have you all here and really exciting to be in person again. And this is, don't say it too loudly, but this is the highlight of the Symposium for the Migraine Trust. As a patient-led charity, this is what it's all about. You are what it's all about from our perspective. So thank you for making the time to join us. We've got an agenda that's been put together with you in mind today. So we're going to be looking at treatments. We're going to do a little bit of research. There'll be lots of opportunities for you to ask questions. And if you're a medical professional in the room, welcome as well. That's fantastic to have you here. And really interesting, as always, to get a patient perspective or a person with migraines perspective on the questions they want answering. So really excited to have you here. And to get us underway, I'm going to invite onto the stage Dr. David Moreno. I can't say it properly in Spanish. I shall try. David Moreno Ajona.
That's perfect.
There you go. Sorry? Yes, we shouldn't we? Apologies. We had intended to do this, and I was so overwhelmed by having everybody in the room, but obviously in honour of everything that has happened this last week and the death of Her Majesty Queen Elizabeth II, we would like to invite you to do a minute's silence. If you feel comfortable standing, that would be perfect. Thank you. David, over to you.
Thank you. And thank you very much for the invitation. So, well, first of all, my talk is going to be about vestibular migraine. I know there are some attendees that are actually following the talk from home, but I'd like to know from your perspective, how many of you, if you can just please raise your hands, how many of you have actually heard of the term vestibular migraine? Okay, it's a good proportion. I would say 70%, roughly. Right, so I'm going to be here maybe. So vestibular migraine, well, these are my conflict of interest. Vestibular migraine, it was, in the past, it was also called migraine associated with vertigo, migraine-related vestibulopathy, or migrainous vertigo. Essentially, it's migraine with vertigo. Here I have put the diagnostic criteria according to the IHS, the International Headache Society, where you can see, well, different points. Essentially, to get the diagnosis of vestibular migraine, or migraine with vertigo, you need a current or past history of migraine with or without aura, and you need what we call vestibular symptoms. Vestibular symptoms or dizziness or vertigo. And those symptoms, or that dizziness or that vertigo, should last between 5 minutes and 72 hours. And then in at least half of these episodes, for the physician to make the diagnosis, we need the patient to have some of the typical migraine features, such as headache on one side, photophobia, or movement sensitivity. That's what should happen. I have been working for Professor Goadsby and his team for the last 4 years, and I have as a headache physician, and also for the last 4 years as a neurology physician at Charing Cross Hospital. So neurology essentially is the DC doctors. So I've been working with DC patients. So the perspective is a bit different. This is the definition of vertigo. So the perspective is a bit different if the patient comes because of a dizziness to a dizzy doctor, or they have headache and the main complaint is headache, and they might also get some dizziness with the headache attacks, and then they usually go and visit a headache doctor. So what usually varies is the intensity. Patients that go to a dizzy doctor or to a neurologist, they would complain of dizziness being the main problem, and when they go to a headache specialist, is usually headache the main problem. But this applies to both type of patients, because migraine with vertigo seems to be, and now we're actually finding out, that is actually very common. So what is vertigo? So vertigo is essentially a sensation of motion. We distinguish, as physicians, we might ask the question to many patients of, is the world or yourself that is moving? When the answer is that it's the world that is moving, we call that a spinning vertigo or external vertigo, with everything spinning around. You can see the last image. You see it's spinning. That's typical for external vertigo. Well, it's more in internal vertigo, when it's a sensation of swaying or being on a boat. The distinction is not clear what it means, because for us it's essentially the same so far. But over time we might actually discover that one type of vertigo responds to a different problem. But for the time being, we call both of them vertigo. When we ask patients, when we ask you, what is your symptom, or how would you describe your symptom, the most typical thing for the patient to do is these, because they feel the spinning or the dizziness. We know that vertigo can be spontaneous, but it can also be triggered by some head positions, some head movements, or even visually induced. What do I mean by these? So as I said, the types of vertigo are the internal vertigo, being on a boat; external vertigo, everything spins around; positional vertigo, that's essentially when you're in bed, for instance, and you turn your head, and then everything spins around. That's positional vertigo. Visually induced. Well, some patients say that they get very dizzy when they're, for instance, watching a movie or a play or in the tube, and they see things passing, and that leads to the dizziness. That's a visually induced vertigo. And then head motion is essentially motion sickness when you travel, and that's actually what makes you dizzy. So what's the usual clinical presentation? As I said, it is different. From my perspective, it's different. The type of patient I see in a neurology clinic is a bit different to the type of patient I see in a headache clinic. So the type of patient I have seen in the neurology clinics are patients who usually complain about vertigo attacks, being vertigo or dizziness the most prominent and debilitating symptom. For most of these patients, most of the patients I see, a very good proportion, their symptoms, their dizziness, last a few hours. So it's medium to long-lasting vertigo. And they usually feel nauseous, they usually feel nausea, and they get movement sensitivity. So attacks essentially feel very, very dizzy for a few hours. They feel sick, they vomit, and then the attacks disappears. It is very frequent for these patients I see, to complain about headaches only a little bit, or they might even say that they don't get headaches at all. While on the other hand, with the patients I see in headache clinics, most patients say that headache is the main problem, that pain is the main problem. And then when I ask them, do you also get a bit dizzy? They would say, well, actually, I do get dizzy. But again, both type of patients would fit the criteria that I showed before. So both patients have vestibular migraine. In my experience working in Professor Goadsby's team, we checked recently, and up to 30% of the patients with chronic migraine had dizziness or some vertigo. So, especially from a neurology perspective, especially for patients whose main complaint is vertigo, we should know what is the differential diagnosis, because it might be migraine, but it might also be something else. And when the episodes are medium to long lasting, so when the episodes of dizziness last for a few hours, the main thing that a physician should rule out is something called Meniere's disease. I don't know if anybody has heard of Meniere's disease. In Meniere's disease, there are three things that are happening that are very, very typical. One is vertigo spells. That is undistinguishable from the vertigo spells of a migraine attack. It's very hard to know. The other one is hearing loss. That would be only for Meniere's disease. You shouldn't have hearing loss because of migraine. And also tinnitus, or ringing in your ears. When you have Meniere's disease, that is typically affecting one side. So a patient with Meniere's disease would have attacks of vertigo or dizziness that would last for a few hours. And also, they would notice that the hearing is worsening on one side, and they would get a tinnitus or ringing on one ear only. While in migraine, that's not expected. It's not typical for migraine. But again, it's in the differential diagnosis, and that's something that we should consider. Well, Meniere's disease, as I said, is there is a triad of symptoms: hearing loss, vertigo spells, and tinnitus. How do we know which one is which? How do we know if they have migraine or if they have Meniere's disease? So we send the patients, I don't know if you have heard, you might have heard if you have dizziness, to something called audiovestibular tests. Essentially, we check that the inner ear is working well. The first graph on the upper left is an audiogram where we check how is the hearing, and there is a typical hearing loss in Meniere's disease at low frequency. That's very, very typical for this disease. And below that, you see what we call the caloric test. With the caloric test, essentially we put hot and cold water into the patient's ears, and that leads, physiologically, it should lead to a movement of the eyes. When there is something called an nystagmus, essentially the eyes move. When you put cold water in an ear, the eyes would move to the opposite side. When you put hot water into an ear, the eyes would move towards the side where you put hot water. That's what physiologically happens. When that does not happen, we know they have a problem. We know they have potentially and probably Meniere's disease. That would not happen with migraine. I don't know if anybody of you have been sent to the audiovestibular tests, but if you have migraine and you have been sent to get these tests done, it is very likely that these tests actually triggered a terrible migraine. Because that's my experience. When I have seen patients that, I don't know if they actually have migraine or might have this Meniere's disease, when I send them to get these tests done, when they come back with a migraine, I actually know they have vestibular migraine, because it's a definite trigger. And the other image is what is happening. The pathophysiology of Meniere's disease is essentially that in the inner ear there is a problem, something called endolymphatic hydrops. A few patients with migraine complain of dizzy spells, and these dizzy spells are not long-lasting. They are actually very short, and they are undistinguishable from something called benign paroxysmal positional vertigo, or BPPV. What is BPPV? Well, BPPV is the most typical type of vertigo. So on average, any of us would experience one of these episodes per life. BPPV is the typical vertigo that you get when you're, for instance, in bed and you turn your head and then everything spins around. That lasts for a few seconds or a few minutes, or with some head position, and then everything's like, ooh, and you have to hold on. That's BPPV. Well, some patients with migraine complain of that symptom, even if it's not as common as the long-lasting dizziness. And how do we know what is what? How do we know if they have BPPV or if they have migraine? With a maneuver, essentially. There is a maneuver, something called the Dixal-Planck maneuver, where we actually, the problem with BPPV, we know, is that inside the inner ear there are some crystals that should not be there. You can see them in this image. So this structure that you are seeing that is like a semicircle is called a semicircular canal. This is inside the inner ear, and it's telling you your head position. When you move your head, this is essentially what physiologically tells you in what position your head is. When you have one of these tiny crystals inside that canal, you feel, your brain tells you that you are in a roller coaster, so everything spins around. There is an actual maneuver to trigger that, so to put the crystal in the wrong position, if you actually have those crystals, And there is a different maneuver to get the crystal out of the canal. Essentially, we would do the maneuver, we look at the patient's eyes, we see this eye movement, this is called nystagmus. At the same time as the patient's having that rotatory eye movement, they also feel dizzy. But we can actually see, as a physician, I can see that the patient is feeling dizzy. And then I do this maneuver, where I turn the patient's head, and then the patient's going to end up standing with the legs hanging and the head straight. And if they do have PPPV, that would be the treatment, and that would be it. While if they have migraine, they would just feel dizzy. But at the same time, if they have migraine and I do the maneuvers, I would not see that type of nystagmus. I would not see these if the patient has migraine. So this is, again, a differential diagnosis. But it's something that should be considered, because some patients with migraine, you are allowed to have migraine and BPPV. You can have two different things. And this is actually quite common. And this is what's happening to the crystal, if you see the last part of the video. And then the patient goes up. And we have got rid of the crystal. Perfect. So, well, this is the neurotological exam. Essentially, this is the exam that I would perform to a patient with vertigo. This is more for neurologists, really. These are these types of vertigo. I've mentioned the most important ones. As I said, it is clearly underdiagnosed. It happens, it is described in many patients with migraine, up to 30%, according to our series. Specific test? No, there is no specific test for vestibular migraine. As I said, the caloric tests are a very typical trigger when I send patients for caloric tests to rule out any other vestibular problem that is usually a trigger, but it hasn't really been addressed systematically. What is the treatment of choice for vestibular migraine? Essentially the same as for migraine. So if you see preventive medications, you might be familiar to some of these. All of them are migraine preventives, as you can see. We say flunarizing as probably the best option because its indication is also vertigo, but it's not available in the UK except for a few sites. But the rest are you could be familiar with. As acute medications, anti-sickness for the nausea, and prochlorperazine. I think it's good that you know about this one because it's also a vestibular sedative, so it can also help with the dizziness apart from the nausea. To conclude, vestibular migraine or migraine is a very common cause of vertigo. Again, the diagnostic criteria say migraine with vertigo. When the patients go to see a DC doctor and a neurologist or an ENT, their main complaint is vertigo. When they go to see a headache expert, their main complaint is pain, but they still fit the criteria on both groups. Meniere's disease is the main differential diagnosis. The one thing that we have to check that they don't have. And many migraine preventives, the ones I showed, the typical ones, are useful, and flunarizine could probably be the first choice. Thank you.
Thank you very much. That was fascinating. We are going to have opportunities for Q&A. We'll just invite up our next speaker first, Dr. Nazia Carson, if he'd like to come up, and then we'll hold Q&A to the end. And I wonder if quickly the Migraine Trust team could stand up and just wave if you're having any problems with Slido, which is the device that we're using to ask questions today, then somebody can help you in that section of the room. Or in this section of the room. Perfect, thanks. Over to you, Nazia, thank you.
Thanks for asking me to speak today. I also work with Professor Goadsby at King's, but I also do a weekly clinic at Great Ormond Street Hospital for Children here in London with Dr. Prabhakar, who unfortunately couldn't be with us today. But I'm an adult neurologist, but I do have a special interest in children and adolescents. And in line with the theme of Migraine Awareness Week this year, these are a really underserved population who can be very disabled by migraine symptoms the same way the rest of us can. So I'm going to talk a little bit about non-painful symptoms of migraine in children and adolescents, again, because non-painful symptoms of migraine are another research interest of mine. Okay. So this slide, I hope, is familiar to you, for some of you, as to what you may experience during a migraine attack, and shown in a kind of current way with emojis. So we know that migraine is not just headache, and that prior to headache symptoms, patients can experience a variety of other symptoms that may warn that the headache is coming and can be equally, if not more disabling than headache. So we know that patients can experience light and sound sensitivity, neck stiffness, concentration problems, cravings, thirst, and also some of the other symptoms that they may experience during headache, like a redness in the eyes, tearing in the eyes, stuffiness in the nose, flushing, sweating, things like that can also happen before pain. I think everybody's familiar with migraine headache, which is characterized by pain in the head and throbbing associated with nausea, vomiting, and some of these light and sound and smell sensitivities. But we also know that lots and lots of patients will experience what we call a postdrome, where even after headache has resolved, they're still disabled by symptoms like tiredness and concentration problems that can really impair their ability to get back to normal function and get back to work. And I'm sure some of you, if not all of you, are familiar with that. Is that right? That real difficulty functioning for up to a couple of days afterwards. And we see that in children as well. So you can start to appreciate the impact that these symptoms in their entirety can have on schooling and education if a child is affected by them. So I'm going to focus on each of the two phases on both ends of the headache phase in a little bit more detail. So the premonitory phase, or the prodrome, to start. So how common is it? So this is a graph that I've made summarizing some of the studies that have looked at how common these symptoms are. And all of the studies in blue are adults, and the studies in green are dedicated children studies, looking at children and adolescents. And you can see that in general, over time, that prevalence is going up. If you look back at that 1980 study versus a study that we've done recently that hasn't been published yet, looking at 35% versus 95%. And that's not because suddenly patients have started experiencing these symptoms. It's because we've increased understanding of these symptoms. Patients have learned to recognize these symptoms. And with both physician and patient education, the reporting of these symptoms has increased. But you can see there that even in the green, even in the children and the adolescents, these symptoms are really, really common. If we look at the children's studies in particular and look at what symptoms people experience, they're actually very, very similar to adults. And the main ones seem to be this overwhelming sense of fatigue, some change in mood, and yawning, which is interesting because yawning comes from a very specific part of the brain and seems to be one of the most reliable and consistent symptoms in this phase of migraine. But you can see as well that there's other symptoms like discomfort in the neck, cognitive problems, cravings, and light sensitivity that also appear. But there do seem to be these three that really stand out as being the most common. And that's very similar to in the adult studies as well. So why do we care about these symptoms? I mean, I think first, they're obviously very interesting because they allude to migraine being so much more than headache, which is obviously something that as physicians and patients, we really want to put out there because it is so much more than just a pain condition. But also because these symptoms can help patients recognize when headache is coming and predict headache. And you can think that if we were able to translate that into trials of treatments, we could start thinking about developing treatments that work before headache has even started and maybe just stop it in its tracks, which I think would be a really attractive option for all of you in the audience and for me as somebody with migraine and for the children and adolescents that we see. So in a diary study conducted by Professor Goadsby's team some time ago, 72% of adults were able to predict impending headache using an electronic diary with these symptoms. And unsurprisingly, the shorter the time the symptoms start relative to headache, the higher that prediction is. And yawning, cognitive problems and mood problems seem to be the most reliable ones and also some of the most consistent ones across attacks. So for those of you that may not have recognized these symptoms as being associated with your migraine, I'd urge you to diary how you feel the day before a headache, maybe 1 to 2 days before, and see if consistently you're able to pick out things that emerge, and they may be able to warn you that headache is coming. And at the moment, that isn't that helpful in terms of treatment, but I think it's helpful in terms of knowing and planning life. And I think the children find it helpful because parents know, okay, he'll be off school in a day or so because these symptoms have started. We're also interested in these symptoms because you can start to think that they seem very similar and associated with some of the things that patients may think are triggers. For example, if you think bright light triggers your migraine and you are exposed to bright light and then get a migraine, you may well make that association. However, if your brain is already acting abnormal before the headache has started and you're sensitive to light, to normal light, then that may well be what is a premonitory symptom manifesting as a misperceived trigger. And that goes in a similar way to chocolate. So if you have a craving, which is a marker that the migraine attack has started, and you crave chocolate, you then take some chocolate and get a headache, you make that association that chocolate triggered your migraine. However, maybe that craving was triggered by the brain already and actually would have made no difference if you had the chocolate or not. And what we see in experimental research is that when you take what patients report as being a trigger and consistently expose them to that trigger, it's actually very hard to consistently reproduce migraine. And we also know, as I'm sure many of you can relate to, that trying to cut things out and modify diet and lifestyle is rarely enough to control people's migraine, suggesting that, maybe some of these what we think are triggers are actually misperceived early changes of abnormal brain function. So we looked at this in a study and found that for light, food, and hunger and skipping meals, there was this association with people that described those as triggers and those people that had those as premonitory symptoms, suggesting that at least to some extent, taking out all the good things in life is not useful for managing migraine, and particularly for the children who often are, deprived of having sweets and chocolate and things like that, and, making sure they drink throughout the school day and things like that, because that's what their parents think may be a trigger for their migraine. May not actually be that useful, but this is something that we want to look at further. Another reason why we care is because with evolving imaging techniques, we can now see that there is imaging changes associated with these symptoms before headache has started. And I think that's really important, that we are able to relay to patients that what they're experiencing is real and it comes from abnormal brain function. And for the first time, we're able to provide imaging changes like what I show here that correlate with those symptoms nicely and show us that actually the brain is mediating these changes and migraine is a brain disorder, not just a headache disorder. So these are some images from a study that I've done where we've demonstrated changes in the area of the hypothalamus, with that figure on your right, which is the body's internal clock and regulates sleep, how much we drink, how much we eat, our temperature regulation, all those sorts of bodily functions. And you can see how things like frequency of peeing, thirst, cravings, changes in arousal could be related to that area. Other areas that control mood and cognition towards the front of the brain are also involved, and we can see that those may well be mediating some of these symptoms that people experience. And then those changes change in headache, and we get this much lower down changes, as you see there, towards the stalk of the brain or the brainstem, which mediates the painful sensations. So really, these changes preceding headache, showing you and showing the children that their brains are abnormal before headache has started and are mediating these symptoms. Similarly, in the postdrome, we know that several people will complain of this difficulty returning to normal function after headache resolution. In general, much more common than the premonitory phase when you look at the literature, including the one study that's been done in children showing above 80% of children being symptomatic of this phase after headache resolution. So a real problem in terms of prolonging the migraine attack and the disability associated with it. The one study in children showed all of these symptoms were problematic in the postdrome, so tiredness, mood change, lack of appetite, concentration problems, nausea, and I'm sure some of you can relate to those, and they're very similar in children too. I'm going to show this video of this young boy who's 11, and has migraine with brainstem aura. He's recently become the paediatric face of the Migraine Trust, so he's got a bit of fame this week. But he's going to very eloquently describe what he experiences before and after headache.
So tell me, what's Mum saying? What happens to you the day before?
I get hyper and silly.
Hyper and silly. What do you do when you get hyper?
Just don't stop laughing.
Sorry?
Non-stop laughing.
Non-stop laughing for no reason. Ah, okay. What else does he do, Mum?
Likes to wind his sisters up.
Do you? Ah,
Doesn't know when to stop. Just very hyperactive.
And the other day, before I had the migraine, we were like laughing about pie or something.
uh-huh. For no reason, eh? You're a bit silly, eh? Right. For the rest of the time, you don't see this behaviour the rest of the time?
You know, he's a very calm,
Yeah.
sensible, well-mannered boy, but
Yeah.
the sort of 2-3 days running up to it, we see
Yeah.
a change in his mood. And so my husband and I have sort of learnt that that's the warning sign now for the migraine. And you can be sort of high as a kite and then get quite low and sulky.
Right.
Okay.
Okay.
Yeah, just sort of a bit of an emotional roller coaster, really. And then,
And this is usually about a day or two before?
yeah.
Yeah.
And then what happens after the attack has ended? How long does he change after that? Well, how long does it take after the attack?
Well, usually in the evening of the day that it's happened, he's just quite subdued and quiet and doesn't have any appetite. And then he'll go to bed, have a good night's sleep, and then wakes up
Right.
back to normal.
Okay. Fantastic. Thank you.
I hope some of you can relate to what that child described. You see, even in an 11-year-old, very eloquent description of those changes that come before headache and have enabled his parents to be able to predict his impending headache. And then that tired, not having much appetite, needing to sleep, problems afterwards that preclude him going to school until he's had that rest. So what do these symptoms tell us? I hope I've described that they start early and they can persist after pain resolution, and that they're quite similar in terms of what people experience before and after. And they may well represent this symptom continuum where things start, maybe become less noticeable in the context of pain, and then persist until the attack has fully stopped within the brain. So in conclusion, migraine, as you know and I know, but is important to recognize even in children and adolescents, is so much more than a disorder of headache. Symptoms before and after can fall into several groups and are related to really widespread brain dysfunction and contribute to the disability associated with each attack. Some symptoms, at least, may start before and continue after headache resolution. We do really need to look at children and adolescents more because they are really underserved in terms of the studies that we do looking at these symptoms in them and looking at treatments in them, as you can imagine. The early symptoms provide us with a really nice opportunity to look at how a migraine attack might start in the brain and how we may be able to develop treatments that work before headache has even started, which I think would be really attractive to all of us. And the phase afterwards provides us an opportunity to understand how an attack stops. So does that stop because of treatment? What about when people sleep or the attack stops on its own? And those are really mechanisms that we don't understand as yet, but I think would be really important research questions going forward so that we can try and develop better treatments for us all. Thanks for your attention.
Thank you, Nazia. That's fantastic. Rob, I think you're going to kick off questions, yeah?
Microphone? Ah, it's working. Right, so I've got some... Hello everyone. I'm Rob Music. I'm the Chief Executive of the Migraine Trust. Just so nice to see so many of you here today. Really, really nice. I look forward to seeing you later on as well, hopefully the breaks, and getting to know some more of you as well. The first question I've got here through Slido is, I have lots of visual disturbances all of the time. Even if I don't have a full-blown migraine, what help should I be looking for to help stop this?
All right. So, well, in general, we can see with migraine patients that they complain of visual disturbances. The typical visual disturbance that precedes migraine attacks is the visual aura, and that would typically last 10-20 minutes. And they would see the typical visual aura is vision of zigzag lines, flickering lights, black spots that spread or move in the visual field from one side to the other. If these visual symptoms, though, are persistent and they are not really connected to headaches, then that should be checked by an ophthalmologist, because it might be an eye problem. It might not be related, strictly related to the headaches.
Thank you. Another question is, can CGRP treatment be used for vestibular migraine?
That's a great question, actually. Well, there are some small studies, but no randomized controlled, placebo-controlled studies in this subgroup of patients. So given that the behavior of vestibular migraine is very, very similar to migraine, the chances are high that they could respond, but there's no published evidence.
Thank you. For Nazia, I think. So, as for migraines in children and adolescents, how often do these young people grow out of their migraines, and what age does that generally happen?
So if you look at the literature, there's a suggestion that in the younger children, the risk of progression to chronic migraine is about half of what it is in adults and adolescents. But then as the children reach adolescence, it then becomes fairly equal to adults. And it's interesting because when you look at children in clinic, when they reach that sort of 15, 16 mark, they do just behave very, very similarly to adults in terms of what they describe and what they experience. And the younger children do often have a more sort of innocent phenotype and have some different symptoms. And those children, you do see them get better as puberty finishes. And so you do see several children get better, more so than in adults, but there is that small group that go on to have quite difficult migraine.
Thank you. I've got one more question on Slido. Is it common to suffer vertigo daily, all day, and what can I do about it?
Common. I mean, it is not that uncommon to experience persistent or constant vertigo. I mean, same as for chronic migraineurs, in some cases, migraine can actually eventually become constant and non-stop. So if that vertigo is connected to the migraine, it could perfectly be the case that they suffer of constant vertigo. If it's not connected to headaches, I would strongly recommend that a patient with constant vertigo or frequent vertigo is checked by a neurologist, because they should rule out, as I mentioned before, some of the differential diagnosis, some of the other possibilities.
Okay, thank you. So one more question has come in. So for either of you, perhaps, what is your opinion on TENS and the TENS machines for migraine treatment, and could these possibly affect hearing?
So essentially, well, the evidence when it comes to the published evidence that us physicians can check and read whether the publications and the trials are published, there is nothing robust, there is nothing consistent, so we cannot really recommend anything on that respect.
Okay, thank you. How are we doing on time? Can we ask any more? Okay, I'm afraid we're out of time in terms of other questions for now. Are you going to be around for a little while, at the break maybe, just in case people can have a chat with you as well?
Of course.
Perfect, thank you. Thank you very much again.
Thank you. We'll see you at the break. I'm sure there'll be lots more questions. And now we'd be delighted if Deborah Sloan could come and speak to us. Deborah very kindly is a member of our community and is going to share her personal story.
Thank you very much, and thank you to the Migraine Trust for inviting me to share my story and my experience. I'd just like to start by acknowledging that each person's experience of migraine is unique, and mine is just one of the estimated 10 million in the UK. But we all have something in common. Each one of us is struggling for an answer. I would also like to say that while I will go on to talk about a very dark moment in my life, I am here now, feeling well, full of hope, I'm very grateful for everything that migraine has taught me. Might sound like a very strange thing to say. And I do know that it is possible to overcome the despair that migraine brought me. But what I will say here at the outset is that while a cure is a holy grail, an effective treatment may be a golden goal, support to help us live with our condition, both as adults and children, is perhaps one of the greatest gifts we could receive. In 10 minutes, it's impossible to convey the multifaceted and complex interlocking elements of my particular migraine experience and its impact on me emotionally, physically, and psychologically. The poet Don Patterson, in four or five lines, says it more eloquently than I ever could. He says, "As for the state of the internal drive, I am a migraineur. Over the years, I have learned how to head off 3 days in the whale by instantly mixing an awful Mai Tai of espresso, propranolol, dextrose, and aspirin, which is no joke at 3 in the morning. I think all of us with migraine can identify with that 3 a.m. reach for the medication in desperation to try to stave off being swallowed into the belly of the whale. So I'm going to go back and focus on one moment 4 years ago, one dark night of the soul, you might say, that encapsulates my own struggle. On this particular night, I lay in my bed, completely disabled, in the 72nd hour of severe pain and vomiting. The question, how would you rate your pain, just wouldn't have applied. Out of 10, I would have said 52. How do you rate pain that forces you to thump your head with your fists or bash your forehead against the wardrobe? Pain that makes even conscious thought hurt. At that moment, I felt I could not do this anymore. It felt like everything that made me me had been devoured by migraine. My career as a busy counsellor ended prematurely when I was in my professional prime. Precious days with family and friends cancelled or ruined. The constant fear of making plans ahead. No treatment had ever worked, and trust me, I had tried almost every type of medication. Neuropathic drugs, antidepressants, anticonvulsants, all the triptans, high-dose aspirin and a glass of cola, anti-inflammatories of every strength, CBD, and every alternative treatment from acupuncture to zinc supplements via Reiki and vinegar. At best, they didn't work. At worst, they produced dreadful side effects and rebound headaches that required me to be hospitalized on several occasions. That was when the darkest thought of my life emerged. The only way this will stop, this level and frequency of pain, is if I am no longer here. Ultimately, I knew that not being here was not an option. I just couldn't have done that to my family and those who I love beyond measure, and I wanted to live. A few days before this dark moment, I had attended an appointment to, as I thought, assess my suitability for a pain management program. But I was told that migraine was not considered an appropriate condition for such a program. A word for how I was feeling as I left the hospital doesn't exist. Hopeless doesn't cut it. So that dark night, I realized I had dropped into the darkest existential crisis. To climb back out would mean until a cure or effective treatment arrived, I would have to come up with a way to live and live the best life I could by devising my own migraine management program. No mean feat when you're exhausted by the ongoing cycle of prodrome, severe pain, dehydration, and postdrome. To cut a long and circuitous story short, here is what I came up with. What I call 3 self-care pillars and a medication cornerstone. I embarked upon 3 things: a low-carb, no-sugar way of eating, cold water swimming, and meditation mindfulness, the cornerstone I'll come to in a moment. I see now that my 3 pillars represent nourishment. Until that point, I had not given much thought about what I put into my body. Low carb, no sugar is not for everyone, but for me, it's made me feel better than I have in years. Empowerment. Cold water swimming gave me a new way of perceiving myself, both physically and psychologically. By wading into the channel on a cold February day, I can't believe I'm saying that, my body is doing something amazing, and my mind is overcoming a huge challenge. I was no longer simply a migraine on legs. Space. Meditation and mindfulness helped me recognize the thought processes that bring me down. I'm a disaster. What am I doing wrong? I should be able to overcome this. Meditation and mindfulness has helped me recognize that now is the only now I have, even if that now is consumed by a migraine. Being able to say to myself, take 20 minutes, stop, be still, gives me the vital space and distance from my migraine mind. The important thing to say here is that I embarked upon all this without any expectation that I would reduce my pain or frequency of my attacks. The amazing thing is that over the course of 18 months, that is what happened. I'm by no means migraine-free. I'd say I'm migraine light. And by migraine light, I mean I get about 1 controllable migraine attack a week. I don't know if it was any, all, or none of my strategies that helped. And I'm certainly not claiming that my 3 pillars could be anyone else's. Let's face it, life without cake is pretty radical. And now to my cornerstone, rimegepant. Just before lockdown, I read about a new anti-CGRP medication which could be used acutely. It was only available in the US. So I raided my pension savings and I made the trip out to New York, had a consultation with Dr. Lipton at the Montefiore Hospital and came home with the first generation of acute anti-CGRP medication called ubrogepant. While it worked well to take away the migraine, its short half-life meant the migraine would keep coming back. The second generation rimegepant has a longer half-life and has proved to be a complete game changer for me. Knowing that I have these tablets in my handbag, I have returned to work. I'm now qualifying as a mindfulness and meditation coach. I no longer carry my awful Mai Tai of cocktail of medication, just 2 small dissolvable discs that have revolutionized my life, giving me the confidence that when a migraine arises, I can more often than not still make it to work. Even more incredible, I'm not destined for, as Don Patterson describes, 3 days in the whale. And while I'm on the subject of rimegepant, I would like to convey my deep gratitude to Professor Goadsby and Dr. Lipton and their teams, not only for their care for so many people with migraine over the years, but for giving the research data on CGRP to the world. I want to finish with something that is a profound part of my migraine experience, my sincerest, most deeply felt wish. Not only that everybody living with migraine should have fair and equitable access to treatment and medication, but that every person with chronic, severe, intractable, life-limiting migraine is offered a place on a pain management programme tailored to migraine. For the 10 million of us in the UK, for the 86 million days of work lost, for the £8.8 billion of lost productivity annually, for the uncountable, immeasurable cost in human terms, I don't think that's too much to ask. Thank you very much.
Thank you so much. What an honour to hear your story. Thank you. appreciate it very much. I think we're now going to take a break until 2:30, if I got my timings right. Yeah, please do take the opportunity to speak with one another and also to ask any questions of any of the medical professionals who you've spotted along the way. See you at 2:30. Perfect. I hope you've all had a good opportunity to talk to each other, talk to people you're interested in. And just a very small point, we have had so many questions for which thank you very much. The questions are anonymised, so we don't know who's asked them, and we are running slightly tight on time, so we won't get to every question, and for that we can only apologise. We'll do our best to ask the questions that have the widest application, but I would encourage you, if your question's not been answered, to try and grab somebody, one of the team, perhaps they can help, but also don't forget about our information and support services and our website, and feel free to email us or contact us and we'll do our best to help. And with that, I'd like to invite Andy Bloor up. Where is Andy? There you are, Andy, thank you, who is also going to share his story.
Hi there. So my name is Andy Bloor, and when I'm not here being a professional migraineur, I am actually a university academic in the field of education. I'm both a researcher and a teacher. And it's very heartening to hear what we heard there about how we monitor the symptoms that we have. When I talk to my research students, sometimes I talk about post hoc ergo propter hoc, the idea that something was caused by it because it followed it, or as I call it, lucky pants syndrome. You've heard it, I'm sure. Oh, I got the job, but I would have. I was wearing my lucky pants. It's like, yes, I'm sure your underwear helped. Possibly also answering the questions effectively was useful. And that's it, isn't it? As migraineurs, we can sometimes find ourselves falling down a rabbit hole. We've got a migraine attack. What caused it? Was it that thing I ate? Or was it that I went past all those trees and the shadows and the strobing? Was it something I drank? How long ago? 24 hours? 48? Last week? When? One of the things I often say to people is that over the next few months, we know that things are going to get financially very tight for all of us. I'm lucky. I've got a reasonably good salary. For me, it means that I'm going to have, maybe the odd less cinema trip, not as many takeaways. Maybe I'm going to have to go for more own brand products. But I also know there are other people further down the line who are going to have to give up a lot more. And the thing about having a migraine is we know that it sucks. Let's face it, it's horrible. It limits things. It means you have to cancel things at the last moment. There's things you'd love to do but can't. It mucks up your life. And that's even before you look at the physiological and psychological and mental effects that it can have on you. And then, of course, then you start chipping away, don't you? Oh, I think chocolate might cause it, so I'll stop having chocolate. Hallelujah, there are studies out there that say, no, it's down to a drop in blood sugar, nothing to do with the chocolate. Get it? But I used to love red wine, and I've had to give that up. And I'm pretty sure that is one of my triggers. Blue cheese? Maybe. And that's it. I was just talking to some fellow guests here and saying, do I cut it out? I mean, I've not had blue cheese since I was diagnosed with migraines. I used to love it. Should I try it? Because if I do, that means I'm going to have 3 days, if it is a trigger, where I'm going to be really ill. Is it worth it? And it's that constant chipping at the edges, taking away a life lived not as fully as our friends and colleagues around us. Now, I was diagnosed over a decade ago, and I'm very lucky that I was one of the first people in the UK to get Botox on the NHS for migraines. I've been through a whole range of drugs, a whole cabinet full of drugs to try and find something that would help stop the migraines, the prophylactic. But that's where we are now. But what I want to just talk about for a moment, in the little time I've got left, is the thing that I don't hear talked about very often. We hear talked about the physical, and goodness knows, the pain. Our previous speakers have spoken very eloquently about that. And it's hell. It's like having a screwdriver driven into your head. There's all the other things. And so we heard about the issue around vertigo and migraine, something my mother, who is also a migraineur, used to suffer from very badly. But I also want to just describe what happens to me before a migraine and what has since, I would say probably for the last 3 or 4 years, become one of my key indicators. And that is that I begin to feel very vulnerable, psychologically very vulnerable. Now, I'm sure we all have our own predominant sort of thing that attacks us. But for me, it is that I begin to feel very fragile. Now, if you're a functioning professional, particularly the sort of person who often has to stand up in front of 200 students and talk with a relative degree of eloquence, it's bad enough if you're struggling over your words. But if you're struggling over your words and actually all you want to do is just curl up on a ball and get a hug, it gets a bit tricky. And I think the thing that I find difficult within the sphere of migraine is that there is a lot of talk about the physiological aspects of it, but not the psychological and mental aspects. And I'm pretty sure I'm not the only one that feels like that. I think we all have times where we feel vulnerable because we are in just such a state, and if I get up, I'm going to throw up, and this isn't very nice. But a lot of us, I think, also feel that utter vulnerability, that utter rawness of existence. And so what I'd just like to finish by saying is just the things that can go right. As I said, I work at the University of Derby, and we used to have small offices, and I shared mine with another colleague. And in that office, I had an old recliner chair. So if I had a bad attack, down the blind, off the lights, on the recliner chair, crash. And then they renovated the whole floor and turned them into larger open plan offices. So I said to them, well, that's very nice, but you probably don't want me putting my old recliner chair in there, so what are we going to do? And they said, funny you should say that. And what they did was they created a dedicated space. This is a space where there is a large sofa, a 6-foot long sofa. We actually test drove various sofas around the university, and that was interesting conversations. No, he's not ill, we're just test driving the sofa. It's got a phone in it. And I'll explain more in a second. It's got a blind, it's got a cushion, a blanket. And if I get a very bad attack, that's my crash space, provided by my employer. Now, the good thing about it is also that whilst I front it, because as I'm sure you can see, I'm a very shy and retiring person, and I have no problem fronting that and being the front face of it. But I know of at least 3 or 4 colleagues who also use it for similar medical difficulties, who would rather not everybody know that they need to use it, but are jolly glad that it's there. And the other thing is that we've got a phone in there. So what I do is I phone down to security and tell them I'm starting to use the room, and when I've finished, I tell them I'm coming out of the room. And that's so that if there is any issue where they need to get me out of the building safely, then we have an egress plan where that can be done. But you know what? It's not rocket science. It's not rocket science, and it doesn't cost a fortune. And I think sometimes we need to feel empowered to ask those questions, because for things like crash space, like for children, having the ability to have water on the table. I mean, I was stunned to hear somebody recently saying that children who have migraines are told they can't have drinks in the classroom. What? Okay, around equipment, chemicals, yeah, fair enough, has to be managed, but what? And the fact is that a lot of the measures that can be put in place to support us and our migraines can very often support other people. And I think that we shouldn't be scared to say, you know what, this is what I need. Remember, if you have migraines, and particularly if they're chronic, it very often will fall under the disability definition as defined by the Equality Act 2010. And because it's a disability, very often getting an occupational health assessment can be very empowering. You might have a lovely boss now, but a year down the line, 5 years down the line, when it's a different person, will you still get the same things? If it's enshrined in an OH report, there's a better chance that you will. But of course, the things that can help us will very often also help other people. And that, I think, is why we should not be scared to ask politely, but firmly, for what we need. And before I finish, just one question for the clinicians. I've got a quick one for you, just see if you can help me with this. I talked about the lucky pants syndrome, you know, not making calls of realities that aren't there. For the last 10 years, every time I have a cold, a common cold, I have no migraines. I often know I'm getting a cold because the migraines stop dead. And I have no idea why. If it was just every so often, I'd be like, well, maybe it's not. Every single time. There's a research paper in that. Thank you very much, everybody.
Thank you, Andy. That was great. Really interesting to hear both of your stories. Thank you for sharing them. And so next up, we have Dr. Ben Wakeley, who is joining us to talk around treatments today.
Good afternoon, everyone. I'd like to thank the Migraine Trust for asking me to speak today. And I'm talking today really as someone who specialises in treating patients with migraine, but also as someone who's had migraine since my mid-teens, and I can remember it being a pretty miserable experience. It was particularly bad when I was a junior doctor, and I think looking after yourself, as the previous speaker eloquently put, looking after yourself and having time outs and things is really important, especially in the busy world that we all live in. So I run the complex headache service in Birmingham, and it's a fancy name, but essentially 98% of my patients have chronic migraine. So these are my disclosures, and this is what we're going to talk about today. So I'm going to talk a little bit about lifestyle. I'm going to talk about acute management of migraine, what preventatives we use, what other options might be available for people that don't want to have tablets. I'm going to quickly breeze through vestibular migraine and menstrual migraine, and then I've just got one slide on the latest drug that's coming out. Okay, so so these discussions are important, and this is once I've established someone's got migraine in my clinic. I do spend a few moments talking about lifestyle, especially younger patients, because younger patients tend to have lifestyles which do provoke migraines. As you get older, you learn that you can't drink as much alcohol. If you skip meals or you get dehydrated or you stay up late, you know that you're going to get a migraine. But people in their late teens and early 20s don't know that. So I'm quite strict with people about, turning their phones off at night, having downtime, sleep hygiene. I think that's really, really important. So I always tell patients, I feel as though I'm nagging them like their parents, but I always say, look, you need to have regular meals, breakfast, keep well hydrated, don't drink too much alcohol. If you're going to drink caffeine, drink it every day. Don't have days where you drink loads and then days that you don't drink as much. Avoid energy drinks, have a regular sleep pattern, and try not to lie in at weekends, try not to nap during the day, because these things, also from my own experience, can trigger migraines. In terms of food triggers, again, I encourage people not to do food diaries, because I see lots of patients who essentially are no dairy, no chocolate, no alcohol, no caffeine, low salt, gluten-free, and they're completely miserable. They've still got headaches. So I say to people, I say, literally, unless it slaps you in the face that it's a trigger, it's probably not a trigger. Okay, so some people it is chocolate, some people it is cheese. For me, it's champagne, which is a real down. If I have a glass of champagne, I will get a migraine. And that's irritating, but that's where we are. The other thing that I talk about to my patients is all about expectations. This can sometimes be a really difficult conversation to have with people. It's expectations about how effective medications are, and what kind of difference we can make, and what the natural history of the disorder is going to be. And you almost, with migraine, you almost feel as though, when you're at your absolute best as a patient, and you're not getting many migraines at all, for no rhyme or reason, you just start getting them. And likewise, when you're really, really bad, sometimes when you don't change anything at all, they begin to get better. And I know this because I'm a general neurologist, and I see patients in lots of different stages of their lives, and sometimes we talk about their previous medical histories, and they'll say, yeah, in my 30s and 40s, I had awful migraine, and then I didn't do anything. It just went away. So I think it is cyclical. Okay. The only good thing about migraine is it definitely goes away when you get older, and that's reassuring if you're in your 40s or 50s or 60s. but it's not reassuring when you're in your 20s. And in terms of my own patient load, I see most of the people I see are middle-aged women. I see far fewer people in their 50s, fewer in their 60s. I see hardly anyone with migraine 70s plus. So it does go away, but it's just it robs you of the most important years of your life. That's the problem. Okay, so acute management of migraine. People tried lots of different things. I think the key thing really is if you have bad migraines, you need to take a combination of medication. Okay, so typically we say you take a strong non-steroidal anti-inflammatory drug, ibuprofen, naproxen, etc., with a triptan, and I'll talk about this in a second, and then with an antiemetic. And the one that I favour is domperidone. As a migraine sufferer myself, I will always just take a couple of paracetamol, a couple of ibuprofen, and a double espresso, and many people do that, and that works for me, but some people do need to have triptans. Okay, so you've probably heard a lot about triptans this week. Essentially, they're agents which cause vasoconstriction, and they also interfere with the release of CGRP, which is obviously very important with migraine. And there's not many reasons you can't give triptans, but we have to be careful in people that have got ischemic heart disease, uncontrolled hypertension, and they don't mix very well with certain other drugs that are used for treating Parkinson's disease and severe forms of depression. Okay, they're generally well tolerated, but lots of people, when they first have them, will say that they sort of get a weird flushing feeling, they get crushing chest pain, and they feel quite odd, and that can really put them off having them. Are they safe in pregnancy? Yes, I think the answer to that is that there are various registries, and lots of women will have triptans without knowing they're pregnant, and there doesn't appear to be a problem for the mum or for the unborn baby. So when should you take them? The key thing is you take them during the headache phase and not the aura phase. Okay, so you take them during the headache phase. We always recommend to people that carry them around with you, because the earlier you get them on board, the more likely you are to be able to terminate that attack. Unfortunately, there aren't really any treatments which are useful for the aura of migraine, and this is really disappointing and frustrating, especially if you're one of those people, usually in your 50s, who get prominent visual aura, which is very disabling, not necessarily with headache, just visual aura, and there's not a lot of acute treatment for it. How often do I take them? The key thing is, for the different triptans, that there are recommendations for each one, how many you're allowed to have per day, and don't go over the recommended amount, and don't mix them. I've had one patient who had a myocardial infarction because they were mixing triptans, and so that's a bad idea. In terms of how often you take them, I'm going to talk briefly about medication overuse in a second, but essentially, if you're taking them regularly on more than 2 or 3 days in a given week for prolonged periods of time, then you are possibly going to develop medication overuse headache, which essentially is indistinguishable from your migraine. So that's a pretty miserable place to be. Okay. Are they safe with migraine aura? The answer is, I think they probably are. And with hemiplegic migraine, people always get worried about whether or not it can induce a migraine can turn into a stroke. I have had a few patients that have had migraines that have turned into strokes, but never in the context of triptans, but we're told that we shouldn't be giving them to people with hemiplegic migraine. A lot of people say, oh, the triptan's not working. I'd always say go up to the maximum dose you're allowed for that particular triptan, and if you tried it 2 or 3 times and it's still not working, then move on to another triptan. And there are lots of different triptans. There's 7 different triptans. Sumatriptan is the one that was invented first, and I guess it's the most basic one. It has the poorest bioavailability, and it probably gets into the system less quickly than the other ones, which are slightly more polished. And you can take these in different forms. You can take them orally. You can take sumatriptan and zolmitriptan as nasal sprays, which some people like. And you can also take sumatriptan as an injection, a bit like an EpiPen. and that can be very useful. And these triptans are used in slightly different situations, and as you probably discovered, most people get prescribed sumatriptan first of all because it's the cheapest and most readily available, and GPs tend not to like giving you sumatriptan injection pens because they're sort of £25 a pop, and we're in a system where there isn't a lot of money. Okay, so if you have triptans which are if you have migraines which are characterised by early vomiting, then it makes sense to be able to get a medication into the system as quickly as possible so that you don't then vomit that medication back up. And that's why nasal sprays and sumatriptan subcut is very useful. If you have headaches which rapidly progress into severe migraines, then you want something that gets into the system quickly as well. And rizatriptan, elatriptan, and almatriptan are useful, as well as the nasal sprays and the injections. Some people will have migraines which sort of linger for a few days, and in this case you want drugs which stick around in the blood for longer, so they have a longer, what we call half-life. And the longest of these is robatriptan, but naratriptan and almatriptan are also useful in circumstances where you have prolonged migraine over a few days. So medication overuse, this is a real problem. It's the commonest cause of secondary headache. What do we mean by secondary headache? This is a headache which is caused by some other factor, whether or not it's an infection or metabolic disturbance. It mimics the underlying headache. So in the case of migraine, people that get medication overuse headache get more migraine-like headaches, and essentially it starts probably when you start getting frequent episodic migraines, so sort of around 10 days of migraine per month, and then you start taking more and more painkillers. It becomes a little bit of a slippery slope, and then you sort of breach these numbers which the International Headache Society have told us that are the thresholds to develop medication overuse, and then things sort of can then spiral out of control. So in the case of triptans and opiates, if you're taking them on more than 10 days in a given month for more than 3 months, then you may begin to develop these medication overuse headaches. With simple analgesics and non-steroidal anti-inflammatory drugs, it's every other day, so more than 15 days a month. Okay, and I think one of the main problems being a migraine sufferer myself is if someone said to me, right, okay, how many days in the last month have you taken painkillers, or how many migraine days have you had in the last month? It sort of gets a bit blurry, so it's difficult to know really, especially in terms of the painkillers. It becomes almost habitual, where you think, well, I take them, they're not really working, but if I don't take them, then I may miss out on them working, even if they probably don't work. So it's easy to get into this state of taking painkillers frequently, and then that can fuel the fire for migraine. Okay, so when do we take migraine preventatives? Well, the general rule is if you're getting more than 1 day of migraine per week, so more than 4 days of migraine per month, then you should probably be on a preventative. But again, it's different for different people. I've got patients that are airline pilots, and if you're an airline pilot and you have migraine with visual aura, it completely destroys your career because you can't fly a plane for 6 months. So these people, even though they get very infrequent migraines, they really want to be on something. But the general rule is if you're having more than 1 a week, then you should be on a preventative. Okay. Now, with the oral preventatives, and I'm going to touch on those first of all, often we're guided as doctors in terms of other things which are going on. Okay, so so-called comorbidities and tolerance to medication. And I'll touch on that in a second. But the key rules are that whatever you're started on, you need to start on a low dose. It needs to be slowly increased, probably at your pace, not the GP's pace. And the general rule is I tell people, look, continue it for 9, 12 months, then come off it, see where you are. because if we think about the underlying cycle of migraine, it may be you just in a good phase and your migraines won't be there. And a lot of people that come off them, the migraines won't be there. So these are the main classes of drugs that we give as preventatives. You'll be familiar with a lot of these. There's anticonvulsants or anti-epileptic medication. Topiramate we use quite a lot. Valproate we don't use, certainly in younger women. Various antidepressants, various drugs which lower blood pressure, and other drugs which are listed at the bottom, including some softer options like magnesium and riboflavin and coenzyme Q10. And as I said, so depending on what other problems you have, we have to avoid certain drugs. So if you've got a background of depression, we wouldn't give you topiramate, because topiramate makes some people feel really low. And although it's probably the best oral preventative, 30% of patients don't tolerate it. And one of the things they report back is just feeling really, really awful. But generally speaking, patients with migraine tend to be more sensitive to medication than people that don't have migraine. So topiramate is an anti-epileptic drug, and in patients with epilepsy, you can give quite high doses, and helps their seizures, and they tolerate it quite well, and they're fine. And then if you have migraine, a high proportion of people just don't tolerate it at relatively low doses. So beta blockers, they can also make you feel low, but they're also used to treat anxiety. And flunarizine, which we don't tend to use very much in the UK, now at least, you can't have that if you've got a background of depression. Depressingly, most of these drugs cause weight gain, except topiramate, which can cause weight loss, and if people waste away, we have to stop it. But most antidepressants cause weight gain, beta blockers can cause weight gain. Pizotofen, again, this really causes a lot of weight gain. I see a lot of young women in their 20s that have been put on pizotofen as teenagers, and it can cause lots of weight gain. And then there are other side effects of topiramate. People generally feel quite tingly, and they can sometimes have problems with concentration and speech. Beta blockers, you have to be careful if you've got peripheral vascular disease. Candesartan can cause a dry cough, and obviously with COVID, GPs wouldn't start it a year or two ago because of COVID. So generally, when I talk to people about oral preventatives, I ask them where they want to dip in. Do they want to dip into the shallow end, which is sort of the softer medications like magnesium, riboflavin? There's less evidence that these work, but they're definitely well tolerated. Or do you want to jump in at the deep end with topiramate, which we think is probably more effective, but unless you're having quite a few migraines and life is really miserable, then you have to weigh up the risks and the benefits of being on these medications. Okay, so chronic migraine, this is when you have more than 15 days of headache per month, of which at least 4 are migrainous. So basically half your life is headache. And if you remember one of the early slides we saw about the prodrome, the aura, the headache, and the postdrome. So if you're having 15 days of headache a month, life is really miserable, because you're either coming up, or you've got a headache, or you're coming down. So you just feel generally rubbish the whole time. But we don't make a diagnosis until you've had this for at least 3 months. Okay. Once you've been through 3 different oral preventatives, I'm going to talk about anti-CGRP, monoclonal antibodies in a second briefly, but what we used to do is give Botox, and Botox is really effective in chronic migraine. It sort of helps at least 70 to 80% of patients. The original trial data sort of indicated that you only had a few. There was a modest improvement in the number of headache days that you gained which were reduced each month. But actually, in real practice, Botox is really useful for chronic migraine. And if someone doesn't respond to Botox, you almost think, have you got migraine? That's how useful it is. Some of you may have had it. It's 31 injections. You have it every 3 months. It's generally well tolerated. And after the initial shock of having those injections, people come back to see me, and they're quite happy because it works. It often doesn't work the first time, so you have to give it a couple of goes, but tends to be a cumulative effect. And especially with COVID, we had to stop giving Botox to people because they weren't allowed to come and see us in the hospital. And when we restarted it, lots of patients were disappointed because after the first set of injections, they didn't receive much benefit, and it's only after you've had 2 or 3 that begins to kick in again. So that's important. Occipital nerve blocks. I'll tell you briefly about these because before the antibodies came along, we used to give these in people that didn't want 31 injections or didn't respond to Botox, and I think they're quite useful. I think that every acute neurologist's friend, if you have a patient on the ward who's got difficult migraine and they want to go home and you want them to go home, give them some nerve blocks, and often that can help. A recent meta-analysis looking at the use of greater occipital nerve blocks didn't really show great benefit actually, but again, in real life, they're reasonably well, they're reasonably well tolerated, and they can definitely be effective. And again, it depends on comorbidity. I've got lots of patients that have a combination of migraine and cervicogenic headache, or migraine and Arnold-Chiari malformation-related headache, and nerve blocks can be really useful. Okay, so briefly, I'm going to talk about anti-CGRP monoclonal antibodies, because you're going to learn about that later. But CGRP is super important when it comes to migraine, and essentially we know that during a migraine attack, your levels of CGRP spike if you take blood from the jugular, and we know that essentially if you neutralize CGRP or the receptor of CGRP, then it can significantly reduce the number of migraines that you have. If you have if you have episodic migraine, then on average about 50% of people will get better by about 50%. And if you have chronic migraine, a similar number of people will get better. So it's definitely revolutionized the way that we treat people with migraine. Generally well tolerated. You can't give them to people with ischemic heart disease, uncontrolled hypertension. If people have got Raynaud's phenomenon, which isn't uncommon, we have to be a little bit careful because it can cause vasoconstriction and make that worse. Okay, and at present there are 3 subcut injections that are available. There's Aimovig, Adjuvig, and Emgality, and Vyepti is the IV version, and this is going to be available hopefully later on this year. Essentially they're licensed for episodic and chronic migraine now. We're not sure about Vyepti yet. Apart from Adjuvig, they're given as just a monthly injection, so it's very, very simple. You get delivered the medication, you keep it in the fridge, you take it out of the fridge, take it out of the box, you put an Alco wipe on your leg, put the pen on your leg, press a button, you hear a click, and that's it. So it's very, very easy to use. And in the case of Adjuvig, you can actually have 3 injections at once, which is really useful if you're going away for prolonged holidays, for example. Okay. Again, in terms of who gets the antibodies, it's the same sort of rules that apply to people that can have Botox. So you've got to have failed on 3 different preventatives, and now there's no line in the sand in terms of whether or not you have chronic or episodic migraine. If you have more than 4 days of migraine per month, essentially you can have these antibody therapies, which has implications for the NHS because that's a very common scenario. When do we stop them? We stop them essentially if they're not working by at least 30%, and if people's migraines get significantly better, then at 12 months we think about stopping them just to see whether or not things are actually better. Okay, so again, you can't use them in pregnancy or breastfeeding. You can't use them if you've got uncontrolled hypertension or ischemic heart disease. Very well tolerated. A small proportion of patients report constipation because CGRP is highly expressed in the gut. and some people report injection site problems, but in Birmingham we have about 600 patients on our books, and a small proportion of people have problems with them. The majority of people benefit from them. And it's interesting, so because of COVID, we stopped giving everyone Botox, and we switched people over to the antibodies. And I think, very few people have wanted to go back to Botox, and the vast majority of people have benefited, and probably more than the sort of initial trial data indicated. So I'm just going to touch on these things for a second, because some people just don't want to have tablets, they don't want to have injections, they want to sort of go along a more natural route. And some of these things there's definitely an evidence base for. So acupuncture is definitely useful in some people with migraine. It certainly helps you relax, and if you're highly strung, and it's a useful adjunct. There are various electronic gadgets which are out there. Some of them look a bit wacky. Kefali is like sort of a Star Trek-y thing that you put on your forehead. It's a supraorbital nerve stimulator, and you use this for acute attacks, and you can also use it every day as a preventative, and it works in some people. The e-Neura is a transcranial magnet, and I think this is something that they specialise more in King's, actually, in London, but essentially it's the size of sort of a tissue box, and you hold it, when you're getting a migraine with aura, you hold it behind the back of your head, and you hear a loud click, and it can help terminate the migraine attack. Gammacore is something that is now used more for chronic cluster headache, but has been useful in some patients with difficult chronic migraine, and this is an external vagus nerve stimulator, and I have definitely had patients who've benefited from these in the past. Precision tinted lenses, people ask me about these all the time. Lots of people with migraine get visual strain, okay, and Arnold Wilkins, who's a friend of mine, invented a machine, I think about 30 years ago now, which is an intuitive colorimeter, which basically works out what colours cause eye strain in individuals, and if you neutralise that colour with a particular lens, and that's why it's called precision tinted lenses, then it can reduce eye strain and it can help some people with migraine. Okay, so my advice here would be, don't buy the off-the-shelf ones from Amazon or eBay that are sort of a funny beigey colour. You need to go, if you're going to do this, you need to have the proper test, and it's with the intuitive colorimeter, and some opticians will do that. Okay, just going to very briefly touch on these things because they've already been mentioned before, but vestibular migraine is a real problem because that feeling of being floaty and slightly sick and just having got off a boat the whole time can make life pretty miserable. And these are some of the things that people talk about. It's not just one thing, it's lots of different things. And apart from the normal migraine treatments, vestibular physiotherapy can be useful, and there's some evidence that playing ping pong and ballroom dancing can retrain your gyroscopes, and that can be useful for vestibular migraine. But by the time people have come to see me, they've sort of probably gone through that already. Apart from using the conventional preventatives, cinnarizine, which is an antihistamine, and lamotrigine, which is an anti-epileptic drug, can be useful in some people. Menstrual migraine, this is a big problem. Essentially, if you have bad migraines, sort of plus or minus 3 days of the onset of menstruation, and not in the rest of the month, we'd call that menstrual migraine. And there are different ways of treating this, either by hormonal manipulation, because hormones are very important when it comes to migraine, especially when the hormones dip just before the onset of menstruation. That's probably what causes the migraine to start. So if you replace estrogen with a gel, a pessary, or a patch, that can be a useful way to smooth out that dip. And I usually tell people, ask GPs to prescribe a 100 microgram patch 3 days before the onset of menstruation, and then cut it in half every couple of days. So you taper the dose over 6 days, and that can be really, really useful. Some women benefit from going on to back-to-back mini pills, and some benefit from having Marinacoil. And if you don't want to go along the hormonal manipulation route, then I would suggest prophylactic non-steroidal anti-inflammatory drugs with a long-acting triptan like frovatriptan, sort of -3, -2, -1, and then a further 3 days around the time of menstruation. This is easier said than done. If you have a very regular cycle, then it works really well, but if you don't, it can be quite difficult. Okay, and the last thing to say, again, you're going to hear about this soon, but antibody therapy is obviously here now, and the next wave of drugs are going to be drugs which are orally taken CGRP receptor antagonists. So they have a much shorter half-life, so if you don't tolerate them, you can stop the medication. And this is important because with an antibody therapy, as soon as it's injected, if you don't tolerate it, which is a low proportion of people, but it's there and you can't get rid of it. So I think this next step is going to revolutionise again how we as neurologists and doctors treat people with migraine. Thank you very much.
Ben, thank you very much. Really, really good. I've got a whole host of questions. We're going to try and fit as many as we can in the time given. First one is, would you recommend Dolovent as a preventative treatment?
Sorry.
Would you recommend, is it Dolovent as a preventative treatment?
Dolovent. What's the other name for that? Right. Okay. So it's one of the green options on my list, isn't it? I think these are useful in people who don't want any side effects, but they probably don't work as well as some of the drugs that you need to be prescribed.
Okay. Thank you. So another question came in, said, I was prescribed triptans aged 40. I've been taking them ever since for 34 years. Is it okay to continue taking them? If not, what is the alternative?
Well, that's a good question. I think it's like this. This person's GP will continue happily prescribing them until that person has a MI or a stroke. Touch wood, that won't happen. But then a red light will come up on that GP's computer screen and they won't be able to get them anymore. I mean, if the triptan works and they're not being taken to excess, then I would be happy for that person to continue them. But we always have to think about medication overuse, especially if you're taking them on more than 2 or 3 days in a given week for prolonged periods of time, because that may be driving the headache.
Okay. Thank you. So I think we've had a few sort of different sort of CGRP sort of questions. There's one here around fremanezumab and whether it's more effective than Botox.
I don't think that they've really done head-to-head trials. I think my personal experience, having given quite literally thousands of people Botox, is that there's not much in it. I think patients quite like having the Botox because they like the contact with the neurologist or the nurse and they can ask about other things. But likewise, there are some people who are quite happy not coming into hospital to have injections and inject themselves at home. So there are advantages and disadvantages.
Thank you. Are there treatment options specifically for the post-drone phase?
Sorry?
Are there treatment options specifically for the post-drone phase?
I'm not aware of any. I mean, I think any medication that energizes the brain could probably be useful. So that's where I'd probably go along the magnesium, riboflavin route if post-drone is a big problem. Migraine is a complex neurovascular disorder, but a lot of it's to do with brain energy as well. So I suspect that could be helpful.
Okay, thank you. There's another question that's come in that says, I've used 3 milligrams of, is it pizotifen, and 100 milligrams of sumatriptan to manage my migraine for the last 40 years. I'm 69. What are my medication options for the future?
Well, I would definitely, well, if it's working, continue. The good news is that this person is getting older and the migraines are going to gradually drift away on their own. But if that person's not happy with the pizotifen, they could try some other preventatives, or, you know, we could up the ante and go into an antibody therapy or something. So, I mean, it all depends where you are on your journey, really.
Thank you. Another question that comes, so sumatriptan via injection is my only relief during an attack. The problem is it only gives me 8 hours of relief and my attacks are 72 hours. How many can I take?
Well, you're allowed to have 2 a day, and you're allowed to have them on 2 or 3 days in a given week for prolonged periods of time. But again, it all depends on, you know, are you the kind of person that has 10 migraine days every 3 months in a cluster of 10 migraine days, or is it spread out?
Okay, thank you. Right, another Botox-related question. So, Botox treatment is not working well since. Not quite sure what that says. Debbie says Botox treatment not working well since bad. I'm not quite sure what that means. Sorry. Since bad and continuing chronic fatigue syndrome relapse. Could this be related?
Possibly, but people with Botox, generally, it's a cumulative effect, and generally speaking, it doesn't just stop working. So there may be something else in the mix there. I mean, the other thing to say is COVID does weird things to migraine as well. So I don't know if any of you have had COVID and found that your headaches have really ramped up, but I see lots of people that have had fairly steady migraine, and then they've acquired COVID and things have changed, and we've investigated them, and you know, they've still got migraine, but it's more severe. So I'm not sure whether or not that's the case here as well.
Okay, thank you. With triptans, should I ask my GP to prescribe or ask for a referral to a headache clinic?
I think GPs can prescribe. The feedback that I get, though, from patients is that it's a difficult time at the moment actually getting hold of your GP, and seeing the same GP is also difficult. And in an ideal world, yes, you would be seen by a headache specialist, but the GP probably knows you best.
Okay. Thanks, Ben. So another one that's come in that says, are there any drugs which are safe for older people to take, i.e. for those over 65?
Well, in terms of, I mean, Botox is definitely safe. Nerve blocks are safe. Antibodies are probably safe, although I don't think there's any good data on people over the age of 65. And then the different oral preventatives, generally speaking, are safe.
Okay. Thank you, Ben. Right, so now that's sort of a triptan-related question. So I've tried a lot, if not all, of the triptans in the past, but none of them have worked. I take cocodamol now. Is this suitable for long-term use?
Sorry,
Is that cocodamol?
Cocodamol.
Yeah.
So cocodamol, that's a combination of paracetamol and codeine. And I've always, I mean, we're always told not to give patients who've got migraine codeine-based medication, but if you are someone who has infrequent migraine and codeine works, then I would suggest that you take codeine. But I certainly wouldn't be taking codeine more than 2 or 3 days a week forever, because you just get into this cycle of medication overuse, and it's actually really difficult to get off codeine.
Okay. Thanks, Ben. So, Debbie, what time have we got? Another couple of more minutes? Okay, all right, so there's a couple more here. What alternatives to amitriptyline could you suggest that won't cause weight gain?
Well, that's well, you could try a different tricyclic antidepressant, or a different antidepressant altogether. So you could try nortriptyline or venlafaxine, but you could try nortriptyline or venlafaxine, but generally speaking, antidepressants do cause weight gain. As I said, topiramate is the only one that probably doesn't. It can cause weight loss, but you can feel very low when you're on topiramate, so it can be a difficult decision to make.
Thank you. Another one, which is, what options are there for patients with chronic migraine who don't respond to CGRPs?
Well, I think combination therapy is good. I've got quite a few people that I see privately who have a combination of Botox and antibody therapy. This is popular in the States. I've seen quite a few people come over from the States who have Botox and Vyepti, which isn't available in the UK yet, and that seems to be quite a good combination. So different pathways, I can't see why we can't give them together, and I think they're definitely helpful having a combination of those.
Thank you. And there's a question about, I guess, anti-CGRPs in young people, but whether they work, and I don't know in terms of when they could be offered as well.
What, you mean
in adolescents?
Yeah, I mean, I think it all depends on how young the person is. I think there's a recent New England Journal paper which looked at different migraine preventatives in adolescents, and I think there wasn't much benefit above and beyond placebo in younger and adolescents, and it was much more to do with lifestyle. But I'm not sure about the antibody therapies, I'll be honest.
Okay, thank you. I think that's all the questions. I think we're bang on time, but thank you again, Ben, very, very much.
So thank you. Thank you very much.
Yes, thanks, Ben. That was really insightful. I can't believe we're at our final session already. Where's the afternoon gone? And we're going to do a double intro here. I'm going to introduce somebody who's going to introduce somebody. And it gives me great pleasure to invite Professor Fayez Ahmed up onto the stage. Fayez I know particularly well because he has been a loyal servant both to the migraine community but also to the trust itself. He was formerly a trustee and is now an ambassador, thankfully, so we haven't lost his expertise. And Fayez, with that, I'll hand over to you. Into the microphone.
Michelle, thank you very much, and Migraine Trust, thank you very much for asking me to do a job that I was waiting to do for a long time. When I came to the headache world in the early 90s, you believe that there were only 4 or 5 headache specialists in the whole of the UK. Could you believe that? Headache was all managed by neurologists or the GPs, and we know how good neurologists are or GPs are in managing migraine. Until somebody arrived in 1995 in the UK, and we saw in the last 27 years a whole sort of paradigm shift. We now have nearly 60 headache specialists in the UK, particularly trained in headache. Plenty of them are working in the UK, and some are actually working around the globe, New Zealand, Australia, Dublin, Ireland, everywhere. Nearly all of them have been trained by that person. The person not only made a lot of progress in the field of science, but he ensured that the clinical benefit of that research gets to everyone, particularly the patients who are actual migraine sufferers. He started his journey from Australia, where he was trained by a legend, Jim Lance, in the field of headache. He's now a living legend himself. I have known him for 20 years. He has inspired me clinically. And by the way, he's a hybrid. He's a good clinician and he's a good researcher. So he inspired me clinically, academically, and as a role model of a very good, down-to-earth human being. I feel privileged to have known him as a friend and as a colleague. He currently works in the King's College Hospital in London. And he was one of the two of the pioneers in the CGRP and the CGRP monoclonal antibody discovery over the last 27 years. So can I invite Professor Peter Goadsby from King's College London to come and tell us a little bit about how he got into that field. Professor Peter Goadsby. So firstly, thank you very much for coming here and also giving me the opportunity to interview you.
Well, I think someone else, I'm not sure I would have given the opportunity if I had the choice, frankly.
So why migraine? What made you choose to come into migraine?
Yeah. Well, can I say something before I answer the question? But I will answer the question. I'm not a politician. It's very generous what you said. I feel a bit like a person who's talking about somebody else, because I don't do much social media and that sort of stuff. I don't see why people are interested in what I've got to say in particular, maybe about headache, but not much else. So I feel sometimes weird when I have conversations like this, because I'm genuinely not that. I've got kids who aren't that interested in what I've got to say. So it's very grounding, I think. And I don't. So I'm going to answer your question, but it's kind of weird for me, I have to say. I thought what you said was very generous. I think legends are dead, and I'm still feeling sort of pretty chipper. So, so how did I get into migraine? Well, I got into medicine largely by accident. I wanted to be treasurer of Australia when I was in school, because I thought the treasurer was a bit of a clown and didn't know any economics. And I liked economics, and I had a really naive view of the world. Maybe I still do. That if you're running the country, you should know what you're doing, and if you're a treasurer, you should actually know about economics. Of course, that doesn't work that way. They just sort of train on the job, which may explain a lot of the problems that we have. But anyway, I got into medical school because I had an argument with my mother about my final school achievements, and just in a fit of irritation, selected medical school as an option on this computer form. So I ended up going to medical school. I didn't do biology or anything like that. It was a real surprise for me that I ended up there, and I wasn't that interested in it all that, I have to say, for the first couple of years. And then you mentioned Jim Lance. He gave a lecture about a brain problem, which I thought was interesting. I thought he was a really interesting guy. And he gave a lecture about migraine when I was in third year medicine. I should never forget it. He's a very polite man, more than me. Actually, his daughter described him at his funeral as unfailingly polite. And he was polite to everyone, even people who were just pigs. He was always polite. At any rate, I came up to it. He talked about migraine. It was 1979. And he gave the explanation about migraine at the time, and I thought it was a pretty silly explanation. And in my youth, if people said silly things, I just used to say to them, well, that sounds silly. And I went up to him after the lecture. Now, he's a global leader in headache, right? He's a professor of neurology and a big guy, big-time guy. I went up to him afterwards, medical student, torn shorts. I had hair at the time. Okay, you find that incomprehensible. Actually, my daughter finds it incomprehensible as well. She wants to get pictures. She asked me if my brother could provide some pictures of when I actually had hair, just to verify that what I say is correct. At any rate, and I said to him, I think this explanation you're giving about migraine doesn't make any sense to me. I mean, it's not sensible. And he looked at me and he said, well, what's your name? And I said, well, Peter. He said, you might be right. Well, why don't you come and help us and come do some work in the laboratory to help us? And I thought, oh, okay, fine, why not? Seems like a nice guy. And then so I went to do. I wanted to do research, and I wanted to take a year off to do research because actually I was refereeing rugby league in Sydney at the time as a hobby, and I wanted more time to train. And so I wanted to get out of the regular course for a year and spend more time training, because there was a time when I could run 20 kilometres at pace. Now, not so much, but so I wanted the time, and I went to see him, and he offered me this work in to do this migraine-related project, and I thought, okay, fine, he's a nice guy, I'll do that. And that's why I got into migraine, because he was tolerant, B, he was smart, and C, he gave me good direction. So it's no surprise that may not come as a surprise to you that his name's James Lance and my eldest son's name's James, and that's no accident. Although he looked at me one day after he found out what I'd called my son, and he said, oh, his name's James, and he looked at me and he said, it's a good name. I said, yes. And he said, well, is that? I said, yes, it is. And he said, oh, thank you very much. He's totally chuffed, I'm sure. He's dead now, so, I mean, but all of that's true. God rest his soul.
See, Peter, when I got into headache, 1992, I remember Frank Clifford Rose was in the Charing Cross Hospital.
He was.
And I chose to go on a headache, and some of my neurology colleagues at that time said, what are you doing? Why are you going in headaches? It's not fascinating. You should choose movement disorders, epilepsy, multiple sclerosis.
Sure.
And I said, well, I end up seeing nearly 2/3 of the patient in my clinic that are headaches, so why not headache? Would you agree that a lot of neurologists do not find headache fascinating?
Oh, yeah, but there's a lot of silly people in the world as well, so that's not exceptional. I was really lucky. Jim Lance thought headache was really important. Really, that was like his top range thing. He did headache and movement disorders. They were his two things. And growing up in a department where the boss, the most senior person, thinks that migraine is really important, then you just think it's important because that's the way it is. And I was shocked, really shocked. The first time when I went to the National in 1990 to do a last part of my training, that they didn't seem hardly interested at all. I thought, what sort of place is this? Because he was really interested. And you talk about training people and so forth. It's partly about environment. If the people around you say something's not interesting, it probably doesn't look interesting. If the people around you say it's interesting, then it makes a big difference. And I think I was very fortunate to train in a department where he thought it was really interesting. But I certainly have had many people over my career say, you seem passably smart, or occasional person saying you seem, actually one guy told me once he thought I was a bit of an overachiever and he was surprised I'd achieved anything, but it's a very strange character. They said, well, why don't you get into stroke? That's more interesting. Really? Someone tried to convince me of that once. One of our senior US colleagues tried to convince me to go and that stroke would be more interesting, or all these other things. They do think that they think that headache's not interesting. It's really strange to me because I don't get that. I think these are fascinating problems. They're important problems. You're able to explore brain function and at the same time understand a disorder that affects just hundreds of millions of people. What's the downside? I don't see it. But you're right.
Well, I mean, since you came in 1995, we now got headache services everywhere. 5 of my 10 registrars in the last 10 years has gone into headache. What did you do to them when you came in? That so many people, even people who did MDs in MS and epilepsy, got into headache. What did you do to them?
I don't think I did anything much. I think that what's one of the important things that's happened is to be able to communicate the biology behind the problem, to communicate the interest, to communicate that that it's exciting, that there's something exciting going on. If you see a person with migraine and you think of them as some sad sop who's sitting there complaining, that's one view of the world. If you see them and you understand that there's complex things going on in the brain, and we start to work out which bits they are, and you get that understanding of it, and you can do something useful. I think it's easy. Doctors like to do good. I mean, that may not have struck you entirely in all the interactions you've had, but I think it's basically true. So if you show them that they can do something good, they usually get sucked into it. Certainly every person I've ever trained, I think it's without exception, is still in the field. And that's because they see that they can do good. And that they also see in the research, I have to say, I don't know if any of you have been involved in research, but they see when we do research, you know, they see people who come along and let us trigger their migraine, give them another one, or trigger their cluster headache. They go in controlled trial. They see that as a group, you're willing to help yourselves. You know, and that's all very motivating, I think. So I think I was just in the right place at the right time and moved a few pieces on the chessboard.
So Peter, I've seen things changing quite a lot. I mean, when I entered the headache, there was Triptan was just discovered at that time, and there was nothing else. All other. Last 20 years, we've seen quite a lot. What was the landscape when you entered in the field of headache in late 80s? Yeah.
Yeah. I started going to Jim Lance's clinics in the early 80s, and for acute treatment was all about ergots, and so the main skill that you had to have was to describe to someone how to cut a suppository in half. I didn't really get into neurology to talk about suppositories, and I'm going to tell you that right now. But you know, if you keep it cool in the fridge and then you heat the knife up a little bit, you can cut it in all sorts of things. You learn a lot of skills that you don't want to have. So it was literally, because ergot's so badly tolerated, the only way it really is well tolerated is if you, put it at the other end, because you don't get nauseated that way. So that was one skill. That was the sort of landscape. And then preventives. And you learn a big lesson in the early 80s. People were using propranolol, Pozzotifen, but almost nothing else that we use now was done then. So you were pretty quickly using methysergide, which is a drug now which is no longer available. Why is it no longer available? Because about 1 in 2,000 people who took it for more than 6 months at a time would end up with this fibrosis, this tissue growing around their kidneys, in their heart or their heart valves. And pretty much every year in the medico-legal journal, someone would be reported who lost their kidney because of methysergide. It's not a very nice drug. However, people with migraine are so troubled by the problem, you tell them all that and they say, sure, just give me the drug, because they want to get better. And then the other thing we were doing, the next drug, was a drug called phenelzine, which almost is never used now. It's an old-fashioned antidepressant. And if you take certain things with it, like Sudafed, for example, or Vegemite, which many of you probably don't take, but I like it. So it's just as an example, or banana skins, whatever you would do that. We had a one-page list. You can get this reaction where the blood pressure goes up, and you can get a little bleed in your brain, you can die and so forth. And numerous times you'd be saying to someone, they tell you history, okay, got migraine, you've had methysergide, didn't work. So the next drug is this drug called phenelzine and blah, blah, blah. And if you do this, you could die. And they'd say, okay, give me the drug. And so you give them a page of instructions on what not to do to avoid dying, because that was not really a good option. And so I learned in that process that migraine is so awful that people are prepared to take drugs with a small chance of dying. I think it's like, as a young medical, like first as a student and then PhD student, it's extraordinary to understand how bad the problem is that this drug seemed okay to use. In retrospect, it just gives me a shiver to think we're ever using it. But that was the landscape. It was just awful.
So Peter, I see the first paper on the CGRP was published in 79 or somewhere.
88.
89.
88.
Then we heard a lot about CGRP in the early 2000s.
Yeah.
Then said, well, this is end of the lines. eventually the CGRP is now available. What drove you and your colleague Lars to push into it in spite of all the setbacks that we had over the years?
Oh, well, it's we wanted to do something useful, I think. We thought by 1990, we'd done two really key experiments that really put, from in our minds, said that this was a target. And that was not, people didn't really accept that till the early 2000s. The 1990s are a bit sort of intellectually lonely in that way. But we thought that this was a target, and it's a big advantage is it wouldn't have this active constriction thing. So we, well, I think we're quite determined to want to deliver something, something useful.
Yeah.
We just wanted to do some good, which is why we never attempted to patent any of it, because that just would have slowed things up. So we didn't do that.
Well, I understand that, but the perseverance, when we had the liver toxicity with the G-pens, I thought CGRP was end of the line.
Yeah, well, you know, yeah, it did look a bit like that at the time, but I was aware that there are other ways of doing it, like the monoclonal. We'd actually developed what's called polyclonal antibodies to various of these neuropeptides in the 1980s to try and to push the experiments forward. So we were aware for years that if you could get the right, if you could do that properly, you would get the outcome. The monoclonal technology came along afterwards. We were working with guinea pig polyclonals. So we were aware that there was a way around it, but you just had to get people interested enough in the problem by persisting. I mean, persistence. People eventually, if you just persist at something, eventually they'll either, you know, get the security to remove you, or they'll acquiesce.
Well, I mean, in 2010, Botox came, and a lot of my patients got better with Botox. Over the last 10 years, I collected or gathered around 200 to 300 patients who wouldn't respond to Botox. And all of them have tried everything else. So I was queuing up to send them all to you to sort them out. And
Thanks.
then the CGRP monoclonal antibody came. And before I started using it, I thought, well, if it doesn't work, what I'm going to do to these 200 patients, I don't think Peter would ever be able to accommodate all of them. And then came the CGRP, and I must say that about 80 to 90% people got better. So 175 people off my shoulder. And I'm glad to tell them that the one who discovered this, I know him personally. So they think I'm probably quite a
well connected. You're very well connected, Fies, but for other reasons.
How do you feel? Because you obviously are the pioneers, you and Lars.
It's like an out-of-body experience for me, as I was saying earlier on. I was watching, you know, Dr. Wakely show this CGRP slide, and I've seen that in many guises many times over particularly the last 10 years, but people have been talking about this thing for a long time. Once we got some traction with the idea, it's quite weird to have, when people talk about something that you've been thinking about for 30 years or longer. So it feels weird. Another weird, I remember the first day I wrote a prescription for a monoclonal. I was writing this thing out, and I thought, wow, who did that? It was very weird. It was very weird, and it still feels quite weird, I have to say. It's like watching yourself in slow motion and thinking, wow, that's very strange.
Well, we've still got about 10-20% people left who haven't responded to CGRP. So what does the future hold for them?
I think a percentage of people, it's pretty clear that there's something about the small molecule drugs that helps. Dr. Wakely mentioned atogepant, and rimagepant was mentioned, I think, earlier on. There's something about them that doesn't make sense, when you first look at it, you think, well, if monoclonals don't work, those small molecule drugs shouldn't work. But that's not like that. That's not what. There's things about these things we haven't worked out yet, which is great. So they're the kind of next wave of what will happen, and they'll take care of some people, and so that you should be really optimistic about that. And after that, there are some really other good targets around. There's one target, another peptide that's called pituitary adenylate cyclase activating polypeptide. Names are getting longer, what can you say? And it's PACAP, it's called PACAP, if you're simpler to say that. There are 3 PACAP target receptors. One of them's been tested not very well. And I think that's a whole other game. And then there's going to be the game of combining things. And then there's a chemical in the brain called glutamate, which is very good at turning nerve cells on. And there are lots of ways to turn them off. One of the problems, if you turn them off too much, you're out, you're unconscious, so that's unhelpful. But there are ways to manipulate that. That'll come along. There are targets in the brain. There's a target called the orexins, which are involved in sleep and involved in pain, that the laboratory folks are working on, which is the importance of research. Why would you be continuing to do research? For the very reason you just said, that not everyone's going to respond to these things, to the CGRPs. We need to know what the best targets are. Orexins, we've seen some work presented here on something called one of the unconventional opioid receptors, the delta opioid receptors in play. There's a range of these targets that the laboratory people are working on, which are going to come along. And, you know, it's fair to say that not everyone in the room is going to maybe even be around when they're available. But it is absolutely crystal clear that our children will be around when they're available. And as long as it's pretty clearly understood that there's a genetic component to migraine, I guess it's our generation's obligation to at least be providing the groundwork for the next generation who will need these other things. And there'll be different ways to use the treatments we have now. There's some interesting things that are being explored. It's just, the next couple of years is just going to be so exciting. It's just crazy. It's just going to be crazy. That's what I can say.
Well, Peter, you've done a lot on the science side of it and clinical side of it. Have you ever been able to change the perception of a common man or a politician or the authorities or health authorities that migraine is not just a headache?
Well, that's something the Migraine Trust's working on, I think, from a policy issue. I was struck. I was talking about politicians. I was waiting to go on one of those Good Morning breakfast or Good Morning Britain or something like that. You know, it's all sitting there, you're just waiting. And the people before me were 3 politicians, 3 MPs, and they were going to go on and talk about who they liked in some reality television show. It was just unbelievable to me that would be something politicians would want to talk about. There are so many problems in the world. They want to talk about their favourite person. Anyway, and one of them, they asked me, they looked at me and they said, well, what are you here for? And I thought, what are you here for? And I said, I'm talking about migraine. And one of them said, oh, that's really nothing, isn't it? Yeah, exactly. And I said, well, not quite, with all due respect, because they're MPs. What can you say? And then one of the other politicians looked at her and said, I've got dreadful migraine. What are you saying? And they started this argument before the television show about whether this was a worthwhile thing and so on and so forth. So some of them know it. One of the things that they're scared of is saying it, because they think it kind of weakens them in some ways. I think that's changing because, social media world's changed that. I think the other thing that's happened in politics, and will have a lot of influence, downstream influence in the next 5 years or so. You mentioned the Brain Prize, which I got with Lars Edvinsson, Jess Olesen and Mike Moskowitz. It's a big deal in neuroscience. And they give you some money, so that was okay as well, I have to say. But it's like a stamp of approval from scientific colleagues that what you're doing is like it's okay, you know, it's important enough, you know, so a stamp of approval. And that's actually really had quite an impact already on research councils. So in the year afterwards, I was invited onto the German, Norwegian, Danish, Swedish, Estonian and Qatari National Research Council evaluation systems. And so all of a sudden they think, oh God, we have to have someone who knows something about this. They look in the list, there's not very many people, so lucky me. And once that starts, once these policy type of people get it that this is something they have to be involved in, that's going to loosen the purse strings for everybody. I think we still have to work on it in the UK a little bit. You know, that would shake them up a little bit. But that's something the Migraine Trust is doing a lot for. You know that that the monoclonals would still be dragging along if it wasn't the grief and aggravation that you all, in coordination with the Migraine Trust, gave NICE. I don't mean grief and aggravation in a bad way if this is being streamed. What I really meant was widespread valuable input. That's what I meant.
So Peter, one thing that is quite fascinating in migraine is aura.
Yeah.
Obviously, from patient's perspective, it's quite alarming when they first experience the aura, and a lot of them worry about getting a stroke, or is it a stroke? What would you tell our patients about what aura is and when they should panic and not panic?
Oh, never panic. Panic is bad. That'll just make you feel worse. So aura is you ought to think about it a little bit like, which this is a simplification, but let's do that. It's a bit like pins and needles when you get in your arm. If you bang your elbow, you get, all of a sudden the nerves don't work properly and you get some pins and needles. Right? You don't have to bang your elbows to have the experience, but if you haven't done that, just ask someone to describe it to you. So you like that. And don't do it too often, because then you'll injure the nerve. But it's a little bit like that. The brain doesn't work properly. It has a little bit of, it turns itself on and then it turns itself off, and so you get the lights and a little bit of loss of vision, or you get some pins and needles, or all the symptomatology. It's transient. It's just like banging the elbow. It will get better. It always gets better. Migraine aura. It's migraine aura. Is vanishingly rare as causes any complication. So panicking there's no reason to panic, because it will get better. I mean, it tells you you're going to get a migraine, so that I understand that's a concern, but it will get better. And the phase beforehand is quite important, this premonitory or prodromal phase that Wakely mentioned as well, because people are thinking quite hard about how to develop treatments in that phase, because that would offer you a treatment where you never had to have pain. Never. Never. So I'm quite excited by that. That's an area, that's why I'm interested in the premonitory symptoms. We've done a lot on this in the last 15 years. I think we kind of put it on the map for people to think about. Nasia has done most of the imaging work and written all the good stuff, and you saw the work that she's done with children. If we could get a way to get a treatment that got in and stopped the attack then, we'd have a viable strategy to really stop the substantial parts of the misery. And that work is just going on gangbusters at the moment. So I'm quite excited by that.
Okay, so just last thing before we start to take any questions from the audience.
Hold on. We're switching.
Sorry.
I just want to let the lady get up here.
Okay, well, what single top tip you would give to a migraine sufferer if he just comes and say, hello, I gather you're a migraine expert and I am a sufferer of migraine?
Oh, find a good physician to work with. Not necessarily me, but no, but seriously, you've got to find someone to work with who will listen to you and who'll ask you questions as well. Don't be afraid of the person who wants to get all the information out of you, because if they just ask you 2 or 3 questions, they're either incredibly brilliant or vaguely not interested at all. So don't be tolerant of people who want to ask you a lot of questions because we're interested, and work with someone who wants to listen to what you've got to say about the responses to treatment so they can help you down the road. But migraine treatment's a partnership. You have to, you've got to hit the ball back. It's like tennis. You've got to hit the ball back when they hit the ball to you, or otherwise you're not going to have a very good game. So find someone you can get on with, that you can work with. That's my advice.
Well, we can take a few questions from the audience if...
Or not.
Yes, we were going to take a couple of questions from the floor. There is a mic roaming somewhere, so please do put your hand up if you have a question for either of our professors, of course. Lovely. Do you want to stand up? That would be great, just so we can see you. Lovely, thank you. And Rob can find you. Lady in the blue first, and then we'll go to you next.
Hello, Peter. Thank you for giving us this opportunity. You're my hero.
Sure.
So thank you very much. Migraine stigma. I've been working with the Migraine Trust and trying to help and support them in any way I can.
Well, thank you.
The past 2 years, all I keep hearing is the fact that everybody just sees migraine disorder as having head pain. But obviously we know that that is not the case. We don't just feel head pain. We don't just have a little bit of vertigo. We don't just throw up here and there. Okay, so for me as a sufferer, I just feel like I'm constantly battling the migraine stigma. Everybody just thinks it is just a headache. And that is something we hear time and time again. So now that we have your fantastic research on the calcitonin protein, how would you feel about possibly additionalizing the name towards migraine condition and having the name of migraine not necessarily altered, but up to a level, to the level that it deems? So potentially, would you consider renaming or additionalizing the name of migraine to calcitonin migraine or calcitonin disorder? Thank you.
Thanks. Fortunately, I couldn't do that because while I chair the classification committee of the International Headache Society, chairing a committee, an international committee, is a United Nations exercise. Doesn't go fast, and there are many voices in the room with views. I think that, high blood pressure, hypertension is not named by the treatments. People understand it's a bad problem. This is a question of understanding more than naming, in my view. People used to think epilepsy was just possession and they'd burn people at the stake. No one would do that. No one I know would even dream about doing that now. And I think there will come a time when no one would say anything stupid about migraine. We have enough biology to show to people that what's going on, and continuing on with the work that we're doing, particularly in the brain imaging side of things, to show what's happening in the brain. I think the problem is that that's what we know is not well enough disseminated, rather than changing anything. So I would rather make education education always works. Eventually, if you teach people enough, they don't do crazy things. So you can stop headhunters eating each other if you point out Kuru, the brain disorder that sends them bonkers. So I would be inclined to put resources into education. Whenever I talk to my colleagues, Buyers will tell you, I start with pictures about the biology. If I'm asked to talk about treatment first, I talk about the biology, because I want them to understand there's not some vague shopping list of things to do. There's biology here, and that's why we're doing it, and get on the program. And I think that's starting to work in terms of biology, so that's where I would go. Ma'am?
Hi, I've got two questions, if that's okay.
You could have three, because we're feeling beyond generous.
One is there any information about when the abortive CGRPs will be available in the UK?
There is. I'm told I have been told that the GPANT, the small molecule GPANT, rimagepant, is likely to get it's licensed, MHRA licensed. So if there was a box available, I could prescribe it now, but they haven't got the supplies. I'm told either December or early in 2023, the supplies will be in the country, right? So it'll go into the private market first. I'm told that. I know that NICE has is looking at it. It will be very important, as the evaluation is done, that if the trust needs your support to make it, again, provide adequate information to the people who are doing the evaluation, that you get behind that, because that's really important. That's going to, what you say as a group, patient group, what your voice says to government in this will make or break how quickly this is done. So when Rob asks for your support, if you don't give it to him, don't ask why it's not around. Really.
Just to add, Peter, the NICE is meeting in December for rimagepant and January for the Vyepta, the intravenous one. We're likely to get approval or not approval decision by April next year.
Very happy to support that. Running out of triptans, so fingers crossed.
Yeah.
The second question was, is there any information about how effective CGRPs are in menstrual migraine specifically?
Yeah, it looks like all the CGRPs to some extent work in menstrual. There's something to say about this. Pure menstrual migraine, just having it around the period, just alone, is relatively rare. That's it's less than 1 in 100 women would have that if you track the diaries and so forth. One of the troops here, Gisela Twint from the Netherlands, presented some very nice work here in a meeting about that. Menstrually associated, meaning you could have it at any time, but also the menstrues make it worse. In the generality of things, when you look back at the monoclonals and the GPANT studies, they work. One of the advantages the GPANTs have in this regard is that they have this really weird thing, very disruptive thing. So at the moment, as Dr. Wakely said, if you take more than 10 days of triptan a month, you might make things worse. Okay. But if you take more than 10 days a month of a GPANT, you make things better. So all of a sudden there's this treatment that ignores the rule about, it just doesn't make things worse. But that's fantastic. I think that's fantastic. So short-term, this is an off-licence thing to say, but it's fairly obvious that short-term prevention, so you might take one of these GPANTs once on every day of the menstrual cycle, or just before of when you're bleeding, or just in the days before, they'll act as a very effective short-term prevention. They're going to be really game-changing, because I'm not suggesting everyone's going to go out and use them like lolly water, but a drug that if you take a little bit more, you get a little bit better, then you don't have to take as much. Well, that's just like we've been looking for that for a long time. So that's one of the optimistic sort of spin-outs from the development of the GPANT. So yes, that's going to be a good thing.
Thank you very much.
Pleasure.
Do we have time for one more question?
I don't know, let me check.
I think we
yes.
do, yeah.
Hi, Peter. I would thank you for your decades of hard work, but I know you find it embarrassing, so,
Yeah,
whatever.
don't do that, no.
In all seriousness, a few people have spoken about stroke, and I know certainly many of us on our first migraine think, oh, crikey, am I having a stroke? Is there anything as migraineurs in particular that we can do to ensure that we don't go down that road? And indeed, anything we should be aware of to think, hang on, this isn't a migraine, this could well be a stroke?
Well, let me give you some good news. If you've got migraine without aura, you don't get the aura. Do you get the aura? You still, okay. Well, if you've got migraine without aura, your risk of stroke is nothing. Okay? I mean, it's the same. It's like everybody else. I mean, at the same age, sex, weight, blah, 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 smoking, family history, exercise, be a good chap, all that sort of thing. And, you know, the actual evidence in the migraine literature is that that males are really not at risk for stroke. So the other thing I'm guessing, but I've had a lot of training at university not to say, but you might be a male. Right. Because my training tells me not to assume too much. But let's say you were. Then don't worry, because there's no statistical risk if you're a male. So that's helpful, isn't it? Just, I mean, if you could confirm you're a male, we're in business. Okay, you don't have to do that, by the way. God. So, the stuff, the courses you have to do sometimes, they send you into a tailspin. God. I'm sorry. It's a serious question, and the risk is really about migraine with aura. And it's a very small risk, is the other thing to say, and don't let the females in the audience go away thinking it's an awful risk. The risk is, the relative risk is maybe 2 or 3 times an age or sex match control, but at a risk rate of, say, 1 or 2 per 100,000. You're only talking about you're only talking about a couple, maybe 6 per 100,000 or 7. So it's double 2, but still that's not many in 100,000. So the risk is quite small. It's a little overemphasised, I think. The other good news is, let me give some other good news, that the risk goes away as you get older. So I'm going to advise you all, if you care to take my advice, to get older. It's the only advice everyone ever takes, isn't it? And by the time you get past menopause, it's back to normal. And the other thing is that you have, the other thing is that there's population evidence that you have no more risk of being demented than anyone else. There's no risk of dementia. You're not going to go gaga in late life if you've got migraine. In fact, most people that you see who've got migraine in later life are crystal clear. The downside is that you're crystal clear enough to experience the pain, but at least you're crystal clear enough to experience it and express it. In all seriousness, dementia is not an issue in migraine, and stroke, the stroke risk is small and it goes away in later life. So let's not walk away thinking stroke is a big deal. It's not really migraine at all. Thanks.
Okay, well, I've been told that the time is up, so thank you very much, Peter. With this, I'll pass it on to Michelle.
Thank you, Fayaz. Much appreciated. And whilst we're doing thank yous, I'd like to thank the team, the Migraine Trust team, who've done an excellent job putting on this event. I'd like to thank everyone who's joined us to speak. You've been brilliant and insightful and helpful. I'd like to thank all of you, primarily, for having joined us today, online, in person. Without you, we wouldn't exist. We wouldn't be able to do the things we do. And I think I'm going to leave Peter with the last words, really, which is there's hope. There's things coming. Let's keep going. Let's keep pushing. And thank you. Have a wonderful evening.